Because remember, they don't have the vocabulary. They don't have that knowledge, that background. So you can give them a nice pretty word that's 5 letters, 7 letters, 10 letters. Those are 10 pretty letters. They don't mean anything. You want to use check-ins, like I was just describing. Do you understand that's a closed-ended question? Don't do that one. Tell me what I said. Or, you know, you want to ask more open-ended questions to get that information out of them to see if they've got it. Clear transitions. So the doctor will go from, how are you feeling, to are you hearing any voices in rapid succession. Psychiatrist, how are you feeling? Are you hearing any voices? Are you taking your meds? Sorry. But they'll ask those in rapid succession. And you have to let the client know that you've changed topics. You have to let them know, okay, how are you feeling? We're done. We're not talking about that anymore. Now we're talking about voices and seeing things. Okay, then ask your question. So you have to make clear transitions. And same thing with referencing. You have to let them know who's talking. Is it the psychiatrist? Is it the nurse? Is it mom? And you have to let them know when it changes. Because otherwise it all just becomes one big blurry mess that doesn't make any sense. Any questions about any of this? Okay. Interpreting techniques. Yay. So we've talked about all this fun stuff of disfluent language and having no vocabulary while they're hallucinating and they're sweating from their medicine. Okay. So simultaneous. This is one we practice a lot. I will be honest, I don't use this very often. I don't use simultaneous interpreting. Every once in a while, I will get a client with a college degree, professional job, and they'll come in for services. Fantastic. I can do simultaneous interpreting. But with my client who spent 17 years with no language, I'm not going to use simultaneous interpreting. So that's one tool, that's one great thing we can use when the time is right. Consecutive interpreting, especially when you have a CDI, when you bring a DI into the room. You're going to use consecutive interpreting. Does consecutive interpreting scare anyone? It did me. When I was just finishing I2P, I'm sitting here going, wait, you want me to hold all of that information and then give, I'm not sure I can hold all of that. But consecutive interpreting is a great tool, especially when it comes to instructions. Absolutely. Because you need to find out what their goal is, what their meaning, what's the meat of it. Okay, I know what you mean, I got it, great, now I'm going to put it on my hands. First person. Does anyone know first person? Can someone tell me? You moved, I caught you, sorry. Right, you're speaking in first person as the deaf person. You're using I statements. Me, I feel, I think, I'm hurting. Sometimes that confuses the doctors. They're like, wait, so the interpreter hurts? No, the interpreter does not hurt. Sometimes they do, but. So first person, that is a technique you can use, especially when you have, like I said, you're higher educated, professional deaf. First person is great. Third person. This is your best friend in mental health. Third person interpreting. So it's also called descriptive interpreting. So you're saying, he's saying X, Y, Z. Or he's talking about, you know, Toy Story or whatever comes to his mind. And so sometimes it's better for the interpreter to describe the language than actually give the language word for word. And especially when you're dealing with the disfluent clients and the language deprivation clients, because remember, it's not going to make sense. And my job is not to make it make sense. The doctor needs to know it's not making sense. So I'm going to describe it to him. I'm going to tell him what I'm seeing. And excellent, like when they're having the hallucination to the side and they're kind of waving them off, even though I'm not going to call it a hallucination, I'll describe it. So have y'all ever done third person interpreting before? Maybe, not yet. You'll get there. You will, and you'll love it, or at least I do. And then glossing. Some interpreters, you're saying, oh, this is my worst nightmare. I'm having to, word for word, what is it? But glossing sometimes can be a great tool. I'll use glossing in tandem with third person descriptive. Because my client, I was referring to that I have to use his name for him to know I'm talking about him. I can't sign you, sorry. I have to sign his name sign for him to know I'm talking about him. And I've explained to the therapist, okay, I'm just going to tell you what he's giving me as he's giving it to me, because it's not making sense. So it's mom, angry, friend left a note, yada, yada, yada. And then we'll go back and I'll kind of describe what happened. But I'm gonna give it to him as he gave it to me sometimes. You don't wanna use it as a default. It's very tough for a lot of hearing professionals to understand this, what glossing is and why I'm using it. But you can use it in tandem with the third person descriptive and really make a clear point of what their language is looking like. Do you have any questions about interpreting techniques? Anything?
This is, I was just having a side conversation about this, but anyways, this has so much overlap with educational interpreting, and so I don't know if some of you might be planning on educational interpreting, and you might think, oh, this is not gonna relate to me. It will.
Yes. Y'all remember at the beginning where we talked about settings where mental health takes place? Everywhere. Everywhere. It's happened today. I've seen mental health going on today, for sure. I've seen my own mental health going on today. I love it. Miriam was going, Catherine, you cannot sit still. I'm like, I am nervous. So, but yes, absolutely. I'm describing these in a mental health concept and mental health settings. But mental health settings are everywhere. So these are tools you can take back and use in your kindergarten class, your VR appointment, the doctor appointment. Absolutely. Especially medical. These are great tools in medical settings too. Because, you know, they're giving you all those fun words of how the body works and what the medicine's going to do to the body and where we're going to do surgery. And if you try to sign just all those words, you're going to wear yourself out. But if you describe it, you're going to get a much clearer picture of what's going on. Thank you, Anna. Okay, so we talked about that. Oh, yeah.
Before you move on, sorry. This kind of relates back to the last slide and this one both.
Okay.
I was thinking about it. I know for certain situations it would be fine, but for the clients that you have that have severe mental health issues going on, you said like with the omissions, not to leave anything out. So just say you're like behind and you miss something. Can you ask again? Like I know in other settings that you ask and you're like, okay, sorry. You ask your client, I missed that, what did you say? I mean, do you still do that in this type of situation?
You can, absolutely. I'll ask the client. And sometimes, I didn't cover it today, but transparency in your interpreting of telling the doctor, this is all he's saying, I missed something. There was something related to this that I missed. And then the doctor can decide to go back and ask. So you can always put that power back in the doctor's hands. But yes, like I said, I ask a lot of questions during an assignment.
If the deaf client, they explain something that they may, and it's not real, and it's kind of distracting, what do we do?
Do your best. That is when you'll use your third person, your descriptive, because you can go, okay, he's drawing some sort of shape in the air, and it's bigger on the top and it gets smaller as you go to the bottom. It's kind of rectangular shaped, and I think he said it's yellow, but sometimes it's green, and so that's when you'll describe it. And sometimes there's not words for what they're but in mental health, you honestly, you do your best. And it's okay to tell the doctor that. Tell them he's not using standard signs. Whatever he is drawing is something in his world or whatever. I don't have a sign for that. I can give you a glimpse of what I'm seeing, but there's no English for this. And that's okay to tell the doctor. And back to transparency, I tell the doctors all the time, nope, I made a mistake, let me go back, we're gonna fix this. I signed that wrong, I used the wrong sign, and I got a different answer than what we're looking for. This is what I did, and this is the response I got. Okay, I'm gonna ask again if that's okay, and this is how I'm gonna change it, and then see if their answer changes. But communicate with the doctor, communicate with the professional. I was about to say they don't bite, but some do.
When you say those types of things to your doctor, how much of that are you letting the deaf client like have access to know? Like, do you sign that that's the conversation you're having? Do they ever see that as rude, or like what's the balance of that?
It's a balance. That's a good word. Very good word. I'll tell the client. I'll tell them, you know, I made a mistake. I made an interpreting error. I'm going to ask the doctor for clarification, and then I'll sign the question again. Or sometimes I'll say to you, hold on a minute, I'm not understanding him. And I might SimCom. It's not perfect language. They're not having 100% access to everything, but they have, it's better than just nothing. Did that answer your question? And it's absolutely a balance in being open with your client, both of your clients, your hearing client and your deaf client, and let them know what I'm doing as an interpreter. Okay, ready to go on? How are we doing on time? Got 30 minutes? Okay, we're gonna pick this up. Etiology, that big fun word, causes. So these are congenital, yay, another big fun word. Congenital causes of deafness. So born deaf. Congenital is something that you acquire, there's the word I'm looking for, acquire before you're born. So congenital rubella syndrome. We've heard this as German measles. It was very popular in the 60s. So a lot of mothers contracted German measles when they were, okay, I might date myself again. Has anyone seen the movie Little Women? Y'all know the movie Little Women? And when the character Beth goes to the house in the woods, and it's the mother and she doesn't speak language, she doesn't speak the same language, and there's a child who can't hear, the baby that's just been born, and they can't hear, and the mom's freaking out. And then Beth comes down with rubella, German measles. So the mom was pregnant and had German measles, which is why the baby was deaf. So people born in the 60s, you'll see this is very common in the 60s. Anyone born in the 60s? So you'll have brief periods of where their language will just not make sense. They'll be signing away, so today I did this, and you know, the sun is yellow and the grass is green, and I went home, and so they'll just have very brief moments of where their language just goes off topic. They have trouble learning new vocabulary. And in a mental health setting, that can be challenging. Because like all the words I've thrown at you today and all the concepts I've just gone, here, have fun. They have a hard time learning that. And they'll copy sign. And sometimes that's really tough when you're trying to figure out if they understand and they sign back to you exactly what you just signed. And you're sitting there going, are you copying me or did you really understand? Yeah.
So rubella, not only does it result in deafness, it can cause other brain issues.
Absolutely.
Which get in the way of language. Okay.
Absolutely. Yes. I'm hitting on how these work with deafness, but a lot of these cause multiple other disabilities and other functioning